So I see Catherine Isham is in the meeting.
Hi, Catherine. Welcome.
She came off mute for 1 second. So we'll just go ahead and get started. We are planning to talk about recruiting underrepresented medical students into medicine in OB-GYN. And so first of all, thank you to APGO for allowing us the opportunity to talk about such an important subject. I have my colleagues here, Dr. Pollock and Dr. Timming. I will introduce myself. My name is Najina Connors. People call me Nina. I am the chair of OB-GYN at Atrium Health in the Charlotte region. And I've been at Atrium for the past 7 years. I originally came here to sort of develop a practice at one of our tertiary care centers and then moved into division director for MFM and then into the chair position. I was interim chair for a couple years and I became the permanent chair towards the end of last year. And so I will be able to share my experience with our recruitment so far since I've been in the chair position. When I was in the division director position, I didn't have so much interaction with interviewing and recruitment and the match list and things like that. So I think I bring a little bit of a different perspective to the recruitment process now. And so I'll let my colleagues introduce themselves.
All right. So my name is Lorene Timming. I'm thankful for you guys for being here today, those of you that are able to join us live, and also excited that hopefully people will be following up on this and watching it later since it's being recorded. I'm an MFM, same as Nina and Becky, and at Atrium Health in Charlotte, North Carolina. We are a academic medical center that's based out of a what was previously like a community hospital, but has lots of residency programs and fellowships, and was previously affiliated with UNC. Now we're affiliated with Wake Forest, and we're a regional campus of them. I am the third year clerkship director, and so this is a topic that's near and dear to my heart, as I think getting URM students recruited into OB-GYN is a critical part of achieving equity in the world. So thanks for letting us come and talk to you today, and I'll pass it off to Becky.
So I'm Becky Pollock. I am the division director for maternal fetal medicine and have served as the associate program director for the last 6 years. And so I've been very involved with application review, interviewing, and that whole scope of practice. And in the last, I would say 2 to 3 years, that experience has changed really as we've made a very intentional effort to increase our recruitment of underrepresented and minority students. That's also coincided with other departmental and I guess system-wide efforts to improve awareness and DEI activity, which I've also been involved in. And so I'm happy for very thoughtful and amazing colleagues, and excited to share this discussion with you all today.
So for our objectives, we will first talk about what is diversity, equity, and inclusion. We hear DEI all of the time. So just to kind of level set and just really talk about what that really means. Then we'll talk about why it's important for medicine and for our residency programs. We all know that it's important. Most of us think it's important, but why exactly is it important? Why is that beneficial for our departments and for our institutions? And then we will talk about how to build a culture of DEI, because in order to be able to successfully recruit students who are underrepresented, there has to be a culture of DEI in your institution. And so people who have a different background, if they don't feel comfortable in your institution, they are less likely to want to join your institution, or even if they do, less likely to stay. And so the other thing, you probably don't want to see my ultrasound. Is that what you're seeing right now? Did the
No,
screen
you
change?
good. We got the same
Play your
screen.
slides.
Okay, my screen changed because my AS was logging me out, so sorry about that. The other thing to say is that we don't have any disclosures for today from any of us. So I'm not sure how many people are on the line.
We got about 4 maybe.
So before we move into definitions, we were planning to do an icebreaker for the group because we really want this to be interactive and not, you know, like didactics. We want it to be interactive so people can kind of share their experiences and we can share ours. So what I would like for the people on the line to do is to share something about yourself that we wouldn't know, obviously, but it's not a physical characteristic. So
I can
wanna go-
start.
okay, go ahead.
Break while other people think of their things. So I think a thing that people don't readily know about me is that I have a passion for musical theater and considered a career in musical theater. In fact, like, can think back to when I was planning my career as a stage manager in musical theater, and obviously I've taken a different direction, but it's funny how often I think that medicine and musical theater are not that different. I could talk on and on about that, but anyway, that's my unique factoid.
How about you, Becky?
I don't know that it's that unique, but it is applicable to this conversation and that, and I've seen a difference. So my maiden name is Epstein, which is like a very common Jewish name, and Pollock is a little bit less so. And so sometimes people don't know straight off the gate unless I tell them that I'm Jewish or I need work off for Rosh Hashanah. And I've thought a lot about that in the last couple of years in terms of like, that's definitely a key part of my identity, but not something that is as obvious as the color of my skin, and how I've certainly faced like discrimination and had microaggressions in that regard, both personally and professionally, but it's not the first thing that happens to me. So anyway, that's my point.
How about Laura Elliott?
Hi, everybody. I guess the thing that I would say is that I'm married to a woman, and I think that that would probably be something that maybe somebody wouldn't know for sure. But that's probably what makes me a little bit more diverse. The color of my skin certainly does not make me diverse. But that's probably the thing about me that is probably, you know, that makes me more diverse in general.
Well, thank you for sharing. Dr. Royce, do you want to share?
Sure. Hi, I'm Celeste. I think it's perhaps on a much more trivial level, but I'm a fairly strict vegetarian, and I do that for ethical reasons. And it can create barriers and sometimes some interesting conversations, especially with older people, particularly back in the day, my mother-in-law. Are the kids going to be healthy? Do they get enough protein? So, yeah.
That's awesome. How about you, Bonnie? Would you like to share something?
I don't really feel like I've been, you know, I'm starting to feel a little bit of the age thing, but other than that, no, I haven't been discriminated at all against.
You can tell us something interesting about yourself. Like,
Well, some of you that have already been on the call earlier, I'm a new grandma, so
Yay.
that's like my new joy.
That's awesome. So I'll share something about myself. So I grew up in Philadelphia. I went to an all-girls public high school called the Philadelphia High School for Girls, and that was a very diverse student body. I had a great experience there. I went to several schools, though, that weren't very diverse. So I went to a school in New Jersey when I was in elementary school, and I was, I think, one of 5 Black students in elementary school. So I was the only one in the grade at the time. And that was a very difficult experience, even though I was really young, because even the children said some racist things. There were, you know, I wanted to be a safety. Like, I don't know if anybody else wanted to be a safety when they were younger, but I wanted to be a safety. And like, they wouldn't let me be a safety. It took like a couple years for them to even let me be a safety. And so that was not a good experience. But then when I started going to school in Philadelphia, it was more diverse, even though it was an all girls school. And that was a great experience. So, you know, we all have things that are very different about us, whether something that can cause discrimination or not. But we also have all these things that are in common, right? And I think human nature is to focus on things that are different versus the things that we have in common. So what are some of the things that all of us just have in common?
If you guys, Allison, Catherine, or Molly, want to jump in, that'd be great. Just anybody.
We're all educators.
Yes,
We all eat food.
we do. We're all here right now. We all love APGO. We all are interested in diversity, or else I don't think we would all be here thinking about this and talking about this. So as far as diversity, the basic definition is just having a mix of identities. And so even on this phone call, this Zoom, we have a range of different experiences and backgrounds. And so we have a diverse group just in this group. And even if we were all of the same racial background, we still have very diverse experiences. And so I think that's one of the mistakes that can be made when considering, especially minority populations, that it's a homogeneous population. And so there's diversity everywhere we look, and we should celebrate that. Equity is really important because we have to remember that regardless of how people are identified or what their experiences are, they have to be treated fairly, compensated fairly, and supported to be able to succeed in whatever endeavor they are involved in. And then inclusion. So we have to value and respect whatever those identities are. What are other ways, what are ways that we're diverse? Like, what do we encounter in our day-to-day life? I mean, race is obvious, gender is obvious. We also talked about sexual orientation, but what other things do we come across that are diverse? Just broad categories.
Religion,
Religion, absolutely.
politics,
Politics, yeah, that's a good one.
Language.
Language,
things like
I
whether
think-
you're a parent or not a parent, or
yep, absolutely.
I think there's like physical characteristic differences. Like I am 4'11", and so like, you know, work wise, like I can't reach things sometimes. And when I do a C-section, I need 2 steps. And I joke when they ask me if I want to sit for my cerclages that the bed doesn't go to the floor, so that wouldn't work for me.
So yeah, you are on the shorter side, but most of us in the group are, so, but we are a little bit taller than Becky. I do use 2 steps for C-sections as well, though. Also, you know, disability, you know, we may not come across a lot of people with disabilities that we work with per se, but you know, we have to be cognizant of that because we do have some residents who have disabilities that at least rotated with us in our institution. And we have patients who come in who have some disabilities. And also economic background is another thing that can diversify our group. So I think that in order for the department and the institution to really buy into why this is important, we have to be able to show why it's important. So this is something that is happening across industries, not just in medicine. And the next few slides are taken from information from Harvard Business Review about why it's so important to have diversity as one of the focuses of your corporation or your entity. And so we know a lot of this came to the forefront because of a couple years ago with George Floyd, right? That really highlighted things around the country with the social justice movement and the protests, and really highlighting something that's been going on for a long time, right? It wasn't a new issue, but it was something that was very public. And then it also coincided with COVID. And so a lot of people were home, not able to go places, maybe home from work. And so a lot of attention was paid to what was going on, in the media. And so that's one reason we should want to improve DEI, because of social justice. But also when places are diverse, that also leads to more employee engagement, and leads to higher levels of innovation. So people who have different backgrounds obviously are going to have different ideas about how to approach things. And so that helps with innovation. It also helps with recruiting and retaining top talent, whether they're from the same background as the people who are working or different. People, especially now, and I think millennials and younger, are really looking for places who value diversity. It also increases consumer satisfaction. So that's really important for us, because we really want to have our workforce more reflective of how our patient population looks. And so patients, I'm sure in your institutions as well, have the opportunity to survey us, to say how well their visit went. And so, even if your provider is not the same race or same background as you, if a patient comes in and they see diversity, that has the potential to increase satisfaction. And so all of these lead to better financial outcomes for corporations and for enterprises. So particularly for medicine, is so important, because medicine is truly a reflection of society. We have to come to terms with and recognize the role that medicine has played in the history of white supremacy, racism, anti-Blackism, I guess it's hard to say that. And then, recognize that structural racism is embedded in the medical education system, and health disparities is also equated with racism. So can anyone give some examples of how race has been used in medicine?
I guess you can think historically about J. Marion Sims and the Tuskegee situation, and all of the situations where Black people were experimented on and not treated appropriately. I mean, there's so much history we could discuss there.
Yeah, that's a talk within itself, right? I think.
Oh, sorry, go ahead.
No, go ahead.
I think one thing that I encounter almost daily is, what are the real differences, genetic, biologic, versus effects of systemic racism and hypertensive disease amongst women of color, and trying to sort out, like, when I counsel patients about that risk, like, what are the different components of that?
Yeah, and I think that's a really important subject, right? And it's hard to separate out things, because we know that Black women have more, they're more likely to have preeclampsia, but is that really a genetic cause? And when we are thinking that it's a genetic basis, then there's room for a basis rooted in racism. And so some of the more recent things that have been used with medicine and race is like the GFR. And so a lot of institutions around the country, including ours, moved to remove race from GFR, because race was initially part of GFR because based on the assumption that Black people have higher muscle mass. And so that was used in the calculation of the GFR. And by doing that, and we know, muscle mass obviously varies from individual to individual, right? And so, but by having that in the GFR, that actually made it so people who would have been eligible for kidney transplant if they were white were not eligible, because your GFR suggested that they weren't a candidate. So that has been removed actually very recently at Atrium, probably within the last year or so that was removed from the lab.
Nina, in the chat, Allison and Celeste are mentioning Grobman.
Right, and Grobman, yeah, that was the next thing that I was going, thank you, was going to mention. And so the Grobman score that we're all familiar with, and so they recently published the Grobman without using race as a factor. But really interesting that it was even initially based on race, right? So we deal with it, you know, every day, even without necessarily knowing that is, you know, behind some of the calculations that we use. Any examples of how structural racism is embedded in our med ed system?
Well, the whole AOA awarding of nominations to AOA based on grades, which are based oftentimes on biased assessments.
Similarly, I think all of our assessment in undergraduate and graduate medical education has systemic bias in it. You know, Allison mentioned test scores, and, you know, even now, as we're talking about applicants, people rapidly look at test scores as a threshold.
Absolutely, and you know, it's great that that's going away with this coming recruitment season, but then it will, you know, it brings some other challenges on how to, you know, get through all of those applications and really review them well, because the test scores, that's an easy weed out, right? So you can whittle down your number pretty easily with just looking at something like that. So certainly in evaluation for residency programs, also for medical school admissions, right? So anything that's involved in admissions, whether it's medical school, undergrad, whatever, that's based on grades and evaluations has potential to be problematic. Also in our patient populations, right? Because the residents tend to see the lower income patients who tend to be underrepresented minorities. And so that can sometimes influence how residents think about patient populations. It also, you know, it's embedded into our society that if you're low income, then if you get healthcare, then, you know, you should be thankful for that. And the people who are learning are the people who can provide you healthcare. And so that doesn't stratify across socioeconomic backgrounds. You know, for instance, in the Charlotte area, the more affluent people, you know, try to not have a resident involved in their healthcare. And so that's a culture issue that's not just in Charlotte, but I think across our country. So we know about healthcare disparities, and we know how important it is to have a good a workforce that reflects our patient populations, because that has been shown to reduce healthcare disparities. Along with George Floyd, we had a lot of attention paid to maternal mortality, as well as maternal morbidity along racial lines. And so that's another reason why it's very important for us to consider diversity when we are admitting to medical school and also recruiting for our residency programs. This is from the CDC. We know that Black women have a higher pregnancy-related mortality than any other group, and that persists across the years. The data is not up to date yet for 2021 or 2022, but it persists across the years, and it also persists across socioeconomic backgrounds. So we know that Black women, whether they're poor, whether they're rich, they still have a higher chance of mortality during pregnancy. So when we look at patterns of healthcare use, we can see that the white population is more likely to use healthcare versus Black or Hispanic or other minorities. And again, very important for providers to look like their patients, you know, not all the time, but it should be in some interactions where patients have providers that look like them. And if you view these pictures, do you notice anything about the pictures that are on here?
the top right, the, obstetrician and the pregnant woman, they look really happy to be together and posing for that photo,
Okay,
as opposed to a couple of the other pictures.
any other observations?
I guess possibly in some of the photos, the gender concordance is there. Some of them there's not. And obviously I think they look happier in general if there's race concordance in your photos.
Yeah, so I agree. I think, and what's interesting is when I put these photos on here, I really wasn't paying attention that much to the differences. I just put photos in here of patients with doctors. And then when I looked at what I put on here, I noticed that on the photos on the right three photos, those look like great patient interactions. On the left, we have the white male physician with the Black woman, and they're not facing each other. He's looking at a chart. She doesn't look very happy, but they look disconnected. And in the one on the bottom left, he's examining, the white male physician examining the Black man, and his gown is down, and it makes me wonder, like, if it were a different patient, would he like pull his gown back up over his shoulder, make sure he's comfortable? But the images are pretty interesting. But to that point, we know that racial concordance increases healthcare utilization in underserved communities. And we also know that gender concordance increases women being willing to do preventative screening. So, we all take care of women, and I can't tell you how many times women tell me that they want to see a woman physician, right? And so, or a woman mid-level. And so that's pretty significant for our field. I'll also say that in the last couple of years, Black women have become much more comfortable and empowered to say that they want to have a Black female physician. And so I'll get a lot when I see patients, do you deliver babies? And I'm like, no, I don't deliver babies, but your doctor is, you're in great hands. But Black women are now feeling more empowered to seek out that kind of care and ask those questions. This is from the AAMC, and it's just a representation of the physician workforce. In the US, the Black population is about 13%. However, the physician representation is about 5%, and that has not changed over time, really. So ACGME released a statement calling for recruitment and training of underrepresented minorities. Things that do adversely affect diversity in medicine is one, institutional racism, also inequality of educational opportunities. And so that goes all the way back to, preschool, elementary school, differences in education, and the path to even get to medical school is pretty challenging. And then also the interview process. And so the interview process is one thing that we personally have control over, right? When students are applying for our residency programs. And so we became very intentional about this, not this past season, but the season before that. And we had a forum that we invited the applicants to, and we discussed an article that was called Interviewing While Black. And that was in the New England Journal of Medicine. And so Becky had a lot of input and a lot to do with the organization around this forum. We also did another one this year. Becky, do you want to tell a little bit about that?
Yeah, this year we sent out the message to have everybody watch this roundtable that was on the New England Journal about dismantling structural racism in medicine. And I'm happy to share that link as well. And then we hosted a sort of guided discussion about that, led by myself and one of our residents. And, I think the biggest thing in after both of those experiences that was really meaningful to me, aside from the value and what I took away from the conversations, and the openness and vulnerability of the participants, both students and faculty, was like during the interviews, the number of students that said, you know, I participated in this forum, in this Zoom, and it really meant a lot to me to just to see that this program was participating in these kind of activities and having these conversations.
Becky, we sent invites out to everyone who was scheduled for an interview, or how do we approach the applicants?
Well, we did, and you know, the biggest way I think people learned about it was honestly through Instagram, because with the virtual interviews, applicants have really been relying on Instagram for program information and updates and sort of to get the flavor of programs. So I think that was a big draw too.
Yeah, I think the residents have been awesome with the Instagram and social media and promoting the program. Were you going to say something else, Lorraine?
Yeah, I was just going to say, I think it was a good step on our part, and I don't want to say bold, but risky a little bit in that we were having these discussions within our department and with our faculty and with our residents, and we the Interviewing While Black article and talking about that talked a lot about things that happened in our in-person interview process, which weren't even happening in the years that we were having these discussions. And then we included applicants in that. So I think that it allowed people to kind of see our vulnerability on these issues and the things we were talking about. It was also cool because if you didn't do interviews, you still got to meet some of the applicants virtually.
Yeah, so, you know, last year when we did the article Interviewing While Black, we actually did that after we did all of the interviews. And that was very provocative because people, you know, some of the people were very open about what they were thinking. You know, we had one of the Black women who talked about her hair and how, you know, she had to think about her hair and how she was wearing it because, you know, somebody might not recognize her from her picture versus, you know, on the interview. And, you know, then we had a white woman talking about how, you know, important diversity is for her and how she's looking for that in the program. So it was very informative. And this year, like Becky said, we did it before the interviews. And so I think both ways were pretty successful. Now we haven't gotten our match yet this year, but last year when we matched, we actually matched our most diverse class that we ever have in the history of our program. And so I think that being open during that interview process and talking and you know, not saying we have all the answers or that we have arrived to where we want to be, but showing that, you know, we're open, we're listening, and this is what we're trying to achieve, what we're trying to work on. One thing in particular is the lack of Black men in medicine, and specifically also in OBGYN. I mean, OBGYN is mostly a female-dominated field right now anyway, but it's very rare, at least in my experience, to see a Black male in OBGYN. You know, older Black men, yeah, but I haven't seen many young Black men gravitating towards OBGYN. And so the AAMC specifically calls out the fact that Black men are very underrepresented in medicine. And this is, you know, it's a lot of factors that play into this, but some of it is certainly implicit and explicit bias. Can anyone want to share any experiences where they have personally or they know about some experiences that have been detrimental when it comes to Black men or in general or Black men in medicine?
I can share a personal experience that happened on our labor and delivery a number of years ago, where a young man who was one of our clerks was a Black man and had expressed some interest. He wanted to go into surgery, but he was so surprised at how much he liked OBGYN. And he had come out to the nurses station And the nurse basically confronted him and, why did you, what were you doing in that room that he had just come out of? And it was, he's like, I was going in to see the patient, and she's like, well, you need to talk to somebody in the staff before you can go into rooms. And it was just so clear that she wasn't seeing him as a colleague or a student, that she was just seeing him as somebody who didn't belong there. And I was completely turned off by it, and I can only imagine, how somebody experiencing that would feel. This is not a welcoming environment for me. I don't, it was sad.
Thank you
And
for
frankly,
sharing.
it was also disappointing in myself because, in those situations, like, how do you, it's hard to respond in the moment to say anything. And
I agree. It's very hard to respond from the person who is receiving it, but also from people who may be observing the interactions. And I think also, not just from the professional side, but also from the patient side. And, when Black male partners are with their the patient who's in labor, and if things aren't going really well or something stressful is happening, and they're asking questions or maybe even raising their voice, they're perceived as much more of a threat than someone who's not a Black male. And so that's something that we also talk about in our program, to be cognizant of these biases that we all bring with us, and to step back and really think about what's happening in any given situation.
I was gonna say, I have a good friend who's a Black male OB-GYN, and I remember him talking about one of the hospitals that we worked at. This was not here, but anyway, where labor and delivery had a locked entryway, and despite his badge and whatnot, he would have trouble getting in that blocked entryway. And I remember hearing that story and thinking, oh my gosh, that's awful and clearly racist. And then since then, I've reflected on, implicit bias is so implicit that you have it and you don't realize it. And I think it's important to check our own internal dialogues. And I, relatively recently had a patient whose partner was understandably upset because they had something going on. And I clocked myself. I realized that my brain was like figuring out where I was relative to the bed and the partner and the door. And that was like deep back there in the recesses of my mind. And then later I thought, I don't do that when it's a white male partner who's getting upset. Like why, where is that in my mind? And then I thought, is that different? If I was on the other side of the glass when my friend was trying to come in with his badge, would I have that response? Anyway, not always proud of those things that happen in the instinctual part of your brain, but they certainly do.
Well, I think, thank you for sharing that. I think it's really important to have dialogue about it. And I think it's also important to note that that's not particular to being white. Like Black people have the same, responses, because we're all fed the same narrative. We're all fed the same media stories. And, so we all have this concept of how certain people behave, even if you're part of that group. And so I think the most important thing is to recognize that and to be honest about that, and to then address it, within yourself, and not let that affect your actions. So the AMC recently, they came up with a pretty comprehensive strategic plan, and you can see it on their website. But three of the things that obviously we're focusing on as far as residency recruitment are focus on inclusivity. So that's in the process, but also if they actually come and work with us, diversify tomorrow's doctors. So that's one of the pillars that the AMC is promoting. And also promote health equity and health justice. So all three of these work together. And that's why it's so important to have these conversations and to really think about how we are recruiting for our future physicians. And so in the end, achieving DEI, it respects our fundamental right to health, safety, and dignity, and notwithstanding any laws that surround that, is just the right thing for us to do. So even without all of the justifications in the Harvard Business Reviews and how it increases your potential financial productivity, it's just the right thing to do to treat people equally and to give everybody equal opportunity. So we're going to move on to building a DEI culture. But before we do, we're going to go around and do a little activity. It's I am, but I am not. So you're going to say, I am this, but I am not this. Who wants to start?
I'll, I'll start just with a tip off from what I said before. I am Jewish, but I'm not stingy.
All right.
I'm overweight, but I care about my health. I can't quite say I'm not unhealthy because, but I'm trying.
Anybody else?
Ooh, I have a good one. I am a working mom, but I really love spending time with my kids. And I really love spending time with my kids.
Anybody else?
Southern, but I'm not slow.
That's a good one. So I'll say, I sometimes yell, but I'm not an angry Black woman.
I am single, but I'm not alone.
That's a good one. All right, so let's move on to building a DEI culture. So as I said earlier, in order to be able to recruit, whether it's residents or faculty into your department, you have to have a culture of DEI. And in order to do that, we have to have strategy around it that's intentional. We have to have people on upper levels of leadership have commitment to it. Like anything else, we have to be able to measure goals and our progress. And we have to be able to communicate the value for DEI, whether that's across the enterprise, the institution, the department, the division, wherever it is, we have to be able to let people know that this is important. So the most critical factors for success are commitment from leadership. We know that we have commitment from national organizations like AAMC, but we also have to have commitment from leadership. It has to be a fundamental part of the business, and it has to be a priority when it comes to strategy. And then there has to be accountability. So we have to have goals and we have to track progress, like I mentioned. The challenges that we know that we have is that at the upper levels of leadership, there's often lack of diversity. We do need greater accountability. It's hard to sometimes measure DEI, so we have to have appropriate tools and appropriate metrics. And then we also have to have training that's appropriate for people who are trying to promote DEI. So when we have commitment from the top, that means that we have a senior person who's in charge of efforts. The CEO communicates progress, and then there are goals that are set for diversity in upper management. And so one example of this is the Vans Corporation with the sneakers, and they publish their diversity numbers on their website. They are committed to doubling Black representation in their corporate office and also to achieving 25% representation for Black, Indigenous, people of color at the director level by 2025. So these are very concrete goals, and they actually are measuring their progress and also making it public for where they're going. So I think that's a great example of how we move the needle forward. For equity and inclusion, we already talked about the definition, but that is critical in recruitment and retention. And so one thing that we really talk about is, when we interview, we then, at the end of the day, the faculty get together, the interviewers, and we talk about the applicants and, you know, the experiences with the interviews. And historically, you know, and this is all the time, people talk about, well, they seem like they would be a good fit. And that, you know, how many times have we heard that? But I try to get us to shift from our mindset of culture fit to culture add, because if someone's fitting in the culture, that's not really bringing diversity a lot of times to what we're trying to do. And so the idea of someone fitting in, we need to try to shift our mindset to what is this person bringing that is something that we don't have, something that makes us better, something that is adding to our group dynamic. So things that we can measure are recruitment, hiring, retention is really important. So we can't just, you know, attract people to come and join us with our presentations and our virtual meetings and our social media. We have to be able to, once they do decide to come and join us, to retain them. And that's a talk in and of itself of retention, because that is very sometimes challenging. And again, the culture of DEI is going to help with retention. And retention is not just during the 4 years of residency, because unless something atrocious happens, people are going to finish their residency, even if they're not particularly happy, because that's the path to getting a job. But retention also is what residents are willing to stay and work with us. You know, who can we recruit into our system that enjoyed working here, even though it was very hard during the 4 years, but they liked the culture that they were part of. And then for the broader level, things like promotions or development opportunities, representation that we see across leadership positions. Compensation is another thing that we're all aware of, and how we're rated in performance. And so that's important also for residents too, right? Because we obviously evaluate them throughout their residency, and we need to make sure that that process is a fair and equitable process. So particularly for Atrium, so Atrium is an enterprise. We have about 70,000 employees. We span across a few states, and we have diversity as a core value. And so we work on it not just at the departmental level with recruitment for faculty and residents, but also we're working on it in our GME for recruitment of diverse faculty across all of the academic departments. We also, in our women's service line, we have committees dedicated to healthcare disparities. And we also, across our enterprise, have another committee that's working on how to diversify our workforce. So it is a core value. There are a lot of things that are going on in the system to try to promote diversity. It helps that our CEO is African American, and so he drives that mission as well. We don't hear directly from him about diversity, but he has certainly put people in places, like our enterprise chief human resources officer is African American. Our chief diversity officer is not African American, but we have a dedicated one for the enterprise. So, you know, he has people in strategic positions to promote our diversity. As far as institutional, we have a chief diversity officer for medical education who has done an outstanding job. She's a ED physician. She's done an outstanding job for really calling to task the chairs in the system. So the chairs, I'm the only Black chair. I'm one of 2 female chairs. And so she has really been influential in bringing together not just the chairs, but program directors, you know, different stakeholders in the organization to talk about how important it is to diversify our residents, our pipelines, you know, for faculty positions, and how important it is to have the culture of DEI. We have a medical education committee task force to recruit and retain diverse faculty, because the more diverse your faculty is, the easier it is to recruit underrepresented minorities into your residency. And then, we have the institutional commitment to diversity in our residency programs. For us in particular in our department, a couple years ago when I became the interim chair at that first interview season, we really started talking about what is going to be our strategy for trying to diversify our residency program. At that point, we had we have some Asian American students. We have a couple of guys here and there. We had one Black resident per every 4 years for, a while. So we had one Black resident who graduated, and then the following year, another Black resident joined. So one of 24. And so the first thing we talked about was how we were evaluating applications. And Becky, do you want to talk a little bit about that?
Yeah, so the first thing we did the first year, we actually removed pictures from the application files. So we were reviewing them like blinded, and you could still see the race ethnicity marker on the ERAS application, but certainly it didn't carry the same weight as when the first thing that pops up on your screen is somebody's picture. And I definitely noticed a difference in some of my initial impressions, because just to acknowledge that implicit bias that I carry. Now that year and also this year, we generally have a screening cutoff based on board scores, which we recognize is going to change anyway. And then we separately, to help increase URM recruitment, reviewed all URM applications regardless of board scores. What was a little bit interesting this year in how just the sorting got done, which I think it wasn't intentional, but even the URM students that had the qualifying board scores, they got sorted out. And so you were reviewing all of the URM applications together with both like above the cutoff boards and below the cutoff, when really like that shouldn't have happened. But I do think that extending that review to applicants that might not have sort of made the cut, so to speak, was helpful.
I was going to add that I think we've all talked about the fact that we're taking these steps, but you're not necessarily there when you've done something. So we've got more to do. And I think as we look at assessment and talk about bias and assessment, I think, we've been talking about, do we need to move beyond even that to where once you've made the cut once you've been offered an interview, the people evaluating don't see other parts of the application like ALA status, which we know has bias built into it, or board scores and those sort of things. And there's obviously a tension that exists there, in terms of working through sheer volume of applicants and deciding who you're going to offer interviews to, and then once you are interviewing at the level of, wanting to recruit the quote best applicants, and I don't know how our faculty would feel about being blinded to the remainder of the application and having it just be on the interview day. But I think each of these steps we're taking is hopefully moving in a good direction.
Yeah, so I was really, I think that was very strong step to separate out the URM applications. I'm glad that the testing is going away, those scores are going away. But I also emphasize to our faculty that, not just because you're underrepresented, that doesn't mean you have low scores. It doesn't mean that you're not prepared, and so, because I think we also have these biases that, she's Black, so I know her scores weren't good. But, actually most of our URM applications have good scores, and the converse happens. So, it came to my attention that someone didn't get an interview from Wake Forest, who, is our partner. And so I reviewed her application, and her application was never even reviewed. She was a white female, and it wasn't reviewed because her step 1 was 205. Her step 2 was like 260 something. And she has like 15 or 20 publications, such strong letters of recommendation, great essay. And it was a huge miss on our part to use a step 1 score to weed out an application of someone who probably would have been a stellar resident if she was interested in joining us. And so we have to be really careful about how we're evaluating. Other things that we do, we spend a lot of time with faculty development. We have a departmental DEI committee that Becky was very involved in the implementation of that. And there's a lot of work going on. I know we're getting short on time, but a lot of work going on with the residents and projects and, you know, ways that we can continue to learn. And right now they're reading Medical Apartheid, and we'll have a journal club coming up. We all have done implicit bias training. We had a faculty meeting that we had discussions around implicit bias, sharing personal experiences, and that was very good. And we also have a mentorship program. I think it's super important to have a safe space for people to be able to talk. So like for Lorene to tell me how she was feeling when a Black man was in the room, like we have to feel comfortable having these conversations, because if we're not, then we don't move forward. We have a lot more to be done. One thing that Becky brought up when we were talking about this workshop is, you know, culture on labor and delivery. Everywhere I've worked, there's always tension between the nurses and the physicians and the residents and whatnot. And so having moving forward with culture on our labor and delivery and those interactions, because if you're an underrepresented resident and you have an interaction with a nurse that's not great, she might have the same interaction with the white residents too, but as an underrepresented person, you automatically are thinking, well, is she doing this because I'm Black? Like, what's going on here? And so we have work to do still, obviously, not just with our faculty and residents, but also in our work environment. And so these are some pictures from when, you know, after George Floyd was murdered, and how our department and our staff, this is in front of our resident clinic, came out, held out signs, people protested, people really united around this. And it was really, you know, great to see. This is another picture of some of our residents and staff. During that time, I felt like it was important to send out something about how I was thinking about it. And so I sent this. This was just personal for me. But again, I think that anyone in any leadership position has to be willing to be vulnerable, to share things with people, because I think that happens in return. And, you know, Becky is great at that. Lorene is great at that. And I think, you know, I'm really, you know, so happy to work with the faculty and the residents that we have the privilege of working with. And so, you know, we want the medical students that rotate with us to see this. We want them to be interested in applying for our residency. And so, you know, these are the things that we're doing. Again, there's still a lot more work to be done. We were going to leave some time to kind of, you know, talk about what people are experiencing in their own departments, but I think that we're almost out of time. And so these are just some questions for thought to, you know, for people to kind of just think about their own places, what they're doing, what they can work on going forward, and maybe what are some barriers that can stop these things from happening, and think about how to face those challenges. So thank you so much for listening to us and participating in our workshop. If there are any questions, we can, I think, maybe take one or two.
Thank you so much. I did want to follow up, because I think one of the big things that we have is we really struggle with not recruiting diverse junior faculty, but with maintaining them and nurturing them. And just wanted to know if you all have any suggestions about how to promote and nurture that young junior faculty member who who maybe was a resident or maybe wasn't a resident, thought that they saw something in your program and then felt left down.
So I'll say that this week we had a meeting with our GME committee that is focused on recruitment and retention of diverse faculty. And one of the things that we talked about was having the importance of having a mentorship program, and not just mentorship, but sponsorship. And so being able to have, seeking out the junior faculty and forming those relationships versus the junior faculty having to seek out somebody who they can then think of as their mentor. I think that would really go a long way in helping to retain. But also we have some focus groups. So we have, different organizations like a multicultural physician group that people can join. There is a group specifically for Black residents in the institution that they can join. So some focus groups are probably important too, so people can just share their similar experiences. But I think the mentorship is really key.
I think also, and I hope it's okay to say this, Nina, but like Lorraine and I love Nina as a person and value her as a colleague and a leader. And when it came time in the chair search to, even evaluate other candidates, we felt like it was critically important to increase representation at the top. Like, so much of this discussion is about building from the bottom up. And I think that there has to be a willingness to change what the top looks like, to not just in terms of physical characteristics and skin color, but like sometimes that like the background might be different. And so defining success in different ways and goal setting in different ways, I think we have to be vocal about that.
And I think we need to see that locally and nationally in our organizations, like redefining, I think assessing the structural inequity and racism in academics and how we measure metrics in academics, like speaking engagements, publications, NIH dollars, all of those sorts of things. I think that we look at that, we're talking about what happens when people are coming in, but where does that play into people's success long-term academically, and how do we like foster that and break down those barriers and how we evaluate people.
Well, thank you all so much for this talk. It was really great. And I know this conversation will continue outside of this session. But again, thank you for the presentation. And I think Bonnie needs to close up the window now.
Okay.
Thank you guys for coming.
Yes, thank you so much. Bye.
Take care.